A beautiful day to you all, and welcome to Timeline, the show that unpacks the issues shaping our world, and of course, where we get to profile solutions to make the world a better place. I am your host, Sharon Ajay, and with me, as always, is my co-host,
Hannah Omokafe Denise, and I'm always excited to be here with Sharon talking about issues that our society faces.
Well, on today's episode, we'll be having a very insightful conversation on the topic primary health care infrastructure in Africa. As we all know, the primary health care is as important as the health of the individual receiving it. And of course, we have a guest to help unpack and dissect this conversation. We'll be going on a short break. When we return, we'll unveil our guest. Stay with us. Welcome back. If you're just tuning in, this is Timeline. Now, our guest is the lead at BudgIT Foundation, the lead of strengthening health system at BudgIT Foundation. And she is Dr. Biobele Davidson. It's good to have you on the show, ma'am.
Thank you very much, Sharon.
Yeah, thank
And
you.
thank you very much, Hannah.
Today, just like I said, we'll be talking about the topic primary health infrastructure in Africa. I know, as we all know, the primary health infrastructure the unit is basically a very important and pivotal aspect of the health sector, and also a backbone of the African health system. But, in Africa, you get to see other countries in that continent not being able to properly deliver quality service to its people. And it makes people to wonder, it makes us to wonder, why is this so? And of course, that is why we're having this conversation. In an era where we are trying to achieve the universal health coverage, this is why this conversation is ongoing, because it is a target that is not meant to be far away from Africa. It's basically what the globe has to come together, leaving no one behind. Of course, that is what we're working towards, right, Omokafe?
Very right, Sharon. And this is one of the reasons why the WHO director, Dr. Tedros, had said that as much as there is a lot of fundings for health services as regards primary health care, when it comes to the infrastructure itself, the problem right there is that there is not enough funding for that. And I think this is why we have our doctor right here. She's going to come and talk about the problems, talk about the solutions, definitely, as regards primary healthcare facilities and in Nigeria.
Interesting.
In Africa.
Yeah, of course. Now, Dr. Davidson, I would like you to share with us, what is the current state of the primary health infrastructure in Africa?
Okay, thank you very much, Sharon and Hannah. It's a pleasure to be here. But before I go into the question itself, I just want to throw more light on what the PHC is, the primary healthcare.
Yeah.
So the primary healthcare is the smallest unit in the healthcare system, and it's actually the bedrock of the healthcare system, because based on the structure itself, the positioning, and then also the governing infrastructure around it, it's the first point of call for people in the community. It's actually situated in a walkable distance to where individuals can access care. And then it also forms the army of, like, if I can use the word army in terms, but it also forms the unit in which majority of the healthcare professionals will actually fall under. So it has that mass coverage for the amount of persons in that geographical location itself. Okay, so looking at the primary health care in Africa, I'll narrow down to, first of all, Nigeria itself. Nigeria has over 30-something thousand primary health care system. But basically, when you're looking at up to level 2, that's the primary health care system that is able to afford the average Nigerian, the basic services it needs. We're looking at a range of 8,000 of them being functional itself. So that's less than 50% of the primary healthcare system itself. Now, what we do at BudgIT Foundation is we work with the community itself. We work with certain structures that have been put in place in the Nigerian healthcare system itself to engage with them to say, okay, how do we look at the current state of your primary healthcare itself? Not just only looking at the building itself, looking at the service delivery, and then looking at how we could also empower citizens to be able to demand accountability, to be involved in the reform process itself. In the last couple of months, there's been a revitalization exercise that is trying to put the building in good condition. So one key aspect that has always been lacking is the feedback mechanism, where people are not able to tell us what it is, the real state of things. So you're looking at a building on the outside, it's painted, it looks nice, it's appealing, and then people go in and then they're not able to get their desired service. You're looking at a building that is in a very poor state, but that's the only healthcare system they have around them. So having that feedback mechanism has been able to tailor the needs of the community. And then when we take those information, leveraging on the WDC and other core stakeholders that gatekeepers in the community, we begin to have different tiers of engagement. So we have engagements at the community level, at the facility level, at the LGA level, at the state, and also at the national level itself. Now, for neighboring countries, I think the last research that I actually did was looking at what does it look like. Okay, so there's a key thing we also need to put in place is that Nigeria has a very large population.
Yeah, of course.
Compared to all the neighboring countries around us. But we've seen primary healthcare system work in places like Rwanda. We've seen places like Zambia. We've seen places like even Ghana, which is Malawi. We've seen them look at how do we tailor the needs of our people to ensure that, one, there's inclusion in the system. Two, there's participation in the system. And then for the inclusion itself, it's not just having male, female, it's also having young persons involved in the system, having persons with disabilities involved with the system, having women involved in the system, and having the youths involved in the system, also having the elderly. Because for us to be able to achieve universal health coverage, like you rightly said, leaving no one behind, there has to be equal representation at the table. People have to have that ownership, sense of ownership. I think at the beginning, when we had engagement, we asked, who owns the primary healthcare system? And everybody will say it's the government. No, actually, it's the community. So looking at other sectors around us, what have they done differently? How have they been able to tailor their resources? This is a very crucial conversation for us to have because there's a lot of transitioning going on. There's a lot of donor funds being cut off. There's a lot of demand from people. And one way that had come to light was during COVID-19 when people could not have access to the big hospitals and everybody started falling back on the smaller hospitals. Looking at the capacity and the strength of the primary healthcare system itself, not just only the infrastructure. So having a beautiful primary healthcare system is one good plus, but then having to have the tailored needs for that community, the service delivery, and then also investing in the capacity of both the health workers and the community members to have that symbiotic relationship where they know and they say, we're advocating for this, we're demanding this, we want to be involved in the process itself, is another way in which we can also raise a form of cooperative social responsibility from the community itself. So there are countries that have made it work. We've seen over the course of the years that under the Minister of Health now, we're having a revitalization exercise that is ongoing in the state, and over 2,000 facilities have been revitalized. So we're ensuring that when people come to the hospital itself, it's inclusive. There are features in the hospital that allow for persons with disability to come into the facility to access care without losing their dignity. So there's a ramp, there's a system that allows people who have mobility issues to come in. And I usually say, sometimes when I go to some facilities prior to this time, and there was a facility where we had walked in and the committee members came in and said, because there was a member with disability in the committee and he found it difficult using the staircase. So they had to take a portion of their facility break and install a ramp itself. That's, for that man, was something that he had to go back, and then he was like an advocate for saying, look, these people listen to me. And then they made sure that I was included in the system itself. So there are other hospitals around Africa that have looked at their resources, looked at their community needs, and then have been able to tailor their services to ensure that everyone is covered, at least the basic itself. People are able to have that basic itself at the primary health care. And I think it's doable.
Yes, definitely. To put the statistics to what you said, because you made mention of the fact that it's not just about raising buildings and making it look aesthetically pleasing, right? You need to be able to meet the needs of the people. Now, according to the African Development Bank's report in 2022, only 51% of primary health facilities in sub-Saharan Africa have access to basic water and sanitation services. And Africa has only 1.3 hospital beds per 1,000 person. Now, compared to 2.1 in Latin America and 6.1 in Europe. To tell you that we are really, really back in numbers if you want to compare them to Europe, of course, and Latin America. And I needed to just, bring this out. Yeah.
Yes. So one of the common feedbacks that we've had from a lot of persons when it comes to the state of the infrastructure itself, the primary healthcare building itself, depending on the different tier, because there are different tiers of the PHC. So you have the health post, you have the PHC, and you have the PHCCs.
Okay.
That's the referral center. So that's where you have the health post it has different cadres. It also has different structure. Nigerian primary healthcare system itself has a defined structure itself, what the building should look like, what the window sizes should be, what the roof should be, where the windows should be located, what the flooring should look like, and all of that. So a lot of persons with feedbacks have always looked at 3 thematic areas when I look at the feedback at the PHC portal. So we have a portal called www.phctracker.org. It's a live portal where people can go and look at the state of their primary health care and also engage and tell us their feedback. It's been divided into 3 segments.
Okay.
One, we need change in infrastructure. That's ranging from we need water, we need electricity, or we need constant electricity. And then the second part is where they're also saying we need expansion, because in the recent times, a lot of persons have been utilizing the PHCs in recent times as opposed to previous times. The next one is saying domestic health workers. We need additional health workers. Health workers gap is like a global problem. It's everywhere in the world. But in as much as we may not have all the capacity filled to brim, can we at least have qualified people to man these facilities? And can we have an adequate number of personnel so that we don't also have burnout, we don't also have fatigue, we don't also have people being exhausted from providing care themselves and then needing care. And then the last thing people are asking is subsidization for medical care. So they want free drugs, they want free medical consumables, or they want subsidized products itself. So those are the 3 thematic areas, but most of them are asking for the basic things. They're asking for water, they're asking for electricity, they're asking for expansion. And those are the common feedbacks that we usually get when it comes to infrastructure. Then a couple of them are going forward to say renovation. So we are now looking at what the NPHCDA is doing. And then we're trying to also update the facilities and also track what they're doing across the 36 states plus 1, which is the FCT.
Great.
Good. That's very insightful. When you look at primary healthcare facilities across the entire world, you notice that the university, it was actually, the document was accepted in 1978.
Yes.
When there was a conference held by the WHO and the UNICEF, where they looked at how they wanted universal health coverage across the entire world. And then this was accepted. And then there were so many countries who accepted it at that time. And of course, we have had revised copies across the world. But then when we look at rural access of this to people who actually need it, undeserved communities, there are certain gaps that still needs to be filled, not just water or basic amenities like you have mentioned. So what are those gaps that are needed to be filled? Because if you look at the some 4 A's, I'm sure you know the 4 A's of primary healthcare, which accessibility is one of them,
yes.
Of course.
Affordability.
Availability. Yes. So how can primary healthcare in rural areas be accessible to these persons?
Okay, so primary healthcare in Nigeria itself. So I'm just going to come down to our context because primary healthcare in Nigeria. So what's happening currently? We have 774 wards, right?
Okay.
So there's actually a primary healthcare across all the wards itself. Now, what we're looking at, and based on when all the technical people are coming on the table to say, how do we sit and ensure that at least there's one functional PHC per ward itself? And then I think we have 774 LGAs and 8,700 and something wards, basically. I think for over 8,000 wards, but 774 LGAs rather. How can we have a functional facility per LGA itself? So one key thing that is lacking in all of this, and one key thing that has been very striking in all of this is community participation. Because in as much as I have beautiful ideas and I have brilliance, and then I have the funding itself, from the plan itself, the community was structured to be part of the system. So that convention that held looked at bottom to top approach, not top to bottom approach. So that also means that that's where now you have that fourth tier, that fourth arm that now looks at the WDC structure itself, the World Development Committee structure itself. So those are respected members of the community that are voted into those positions to be able to speak, to be able to harmonize the voices of the community itself. So underserved communities are usually the primary recipients of those primary healthcare themselves. Now, based on its location itself, it's supposed to be accessible to that community itself and then to neighboring communities within a short distance or a short radius mile or 15 minutes walk at max, I think. But a lot of times we find out that there's a facility there, people just go there. They do not know that they're supposed to engage in facility meetings. They're supposed to engage in community meetings. There's supposed to be like awareness sessions coming up from the facility to the community. And then also there's supposed to be a feedback that comes from the community to the facility themselves. And then there's also a portion where facility in charges are also supposed to sit with WDCs and other respected members to develop their business plan. So looking at the different gateways of health financing that goes to those facilities, they are supposed to use that funds to tailor to the need of the facility itself.
Interesting.
So because there are these knowledge gaps, and funny enough is, I'm going to say this, a lot of these meetings that I held up until recent times were mainly held by one particular gender. So, but most times when you look at the statistics, the number of people who use the facilities are usually the women and children most times, but a lot of times, so we're not seeing how do we also have female representation, especially women leaders, and then youths and young persons. So having that holistic picture itself improves not just the facility output, but also the health outcomes at those facilities themselves. Because when community members come together, they are able to tailor their needs to what is existing in that community. Health awareness, health sensitization exercises will also be based on their context themselves. And then they're also able to tailor what they need and also see that their health outcomes also improve across the board. So that helps, right?
Of course.
Awesome.
Interesting. Thank you, Dr. Davidson. This is quite an interesting conversation, of course. We'll be going on a short break, and when we return, Omo Cafe will take us through social commentary. Stay with us.
Culture connects us beyond borders. It's a bridge between traditions, creativity, and the future.
Culture is alive, shaping identities and communities every day.
Art tells stories of resilience and vision.
Artists blend tradition with innovation.
Cultural preservation creates sustainability and empowerment.
Culture evolves and adapts.
Music and dance unites communities through movement.
And right here, in the heart of our cities, artists and creators are keeping these cultures alive.
On Culture Cove, let's explore,
celebrate, and preserve the arts and culture that define us.
Welcome back. If you're just tuning in, this is Timeline. Omo Cafe, over to you.
And we're still on primary healthcare accessibility, of course, in Africa. And when we get to look at it, we have been able to rightly define that primary healthcare is supposed to be accessible to every single person. In fact, it is one of the factors that leads to qualifying that Sustainable Development Goal 3 is achieved before 2030 and is supposed to be across several communities in the world. And right here, this particular tweet is from And NANYD Africa says that rural health facilities often lack staff, equipment, and AHD services, leaving children behind. Policymakers must invest in infrastructure, staffing, and supplies, ensuring that no child is left behind. This is one of the things that we were talking about when we said that children, especially, not just women who are being talked to or men who are constantly being talked to about primary health care or the facilities in it, but we have to look at how people can be represented, just like children, young person. You had made mention of young persons and children and women, and this is just one of it. And one of the problems they mentioned right here is the fact that rural facilities often lack staff, which is actually a question I think I would actually like to ask you. WHO had said that they had recommended that there should be at least 1 to 600, one patient to, is it 600? 600 patients. So
To one doctor.
To one doctor. So is it possible that rural health facilities can be able to achieve that, considering the many problems that they have?
Okay, so I said earlier that global human resource for health is a global problem. So it's not just limited to Nigeria itself. That's why you find a lot of people migrating to greener pastures. But all in all, I've always had this notion, and I always say to somebody, to people when I'm in a room, I say, if your child had an opportunity to leave to another country for better opportunities, will you say stay or leave? So that's a rhetorical question.
Yes.
But for those persons who are currently in the system, what incentives do we have? And it's not just about pay itself. Incentives that look at opportunities for growth, incentives that look at better welfare for the people involved in the system, incentives that look at also building capacity and also ensuring that, in as much as we're saying that human resource is a global problem, can we have at least a functional health system with adequate staffing that would ensure that good quality service is provided, and also ensuring that the welfare and the mental health of those care providers are also factored in. That's one thing. So human resource is something that we have been advocating for. Most of the times when you look at the feedback at the PHC portal itself, the tracker portal, a lot of persons are saying, we need additional staff, we need additional staff, we need additional staff. And I think recently there's been a lot of ongoing recruitment in some states. Some of the honorable commissioners and ESs are also listening and saying, okay, how do we boost our work capacity itself? How do we ensure that we get people? Now, something that is also fizzling out is the fact that there's also this margin where you have a lot of elderly people in the system transition, and then they retire, and then there's the gap, and then you have a lot of younger persons looking out for greener pasture. So you're going to have that gap. How do we also ensure that our training institutions are actually functioning optimally to ensure that there's knowledge transfer? So it's not just also churning people. Health itself needs that guidance. You need the right people to mentor the next generation, to pass down the same etiquettes, to pass down the same morals, to pass down the same standard of care that they have also been taught. So how do we also ensure that the right persons who are coming in have the right information? And beautiful is the fact that we now have digital tools. How do we also harvest these digital tools to also shift from the conventional, traditional method and adjust to the current trend of times itself? So digital medicine is something that would also help to ease the burden and the load in terms of when it comes to staffing itself. So those are some things that people in the ecosystem have also been advocating to.
Interesting. Let's look at this one from Dr. T. Baba, Commissioner for Dodo. It says, if the PHCs are working well, the general and teaching hospitals will be less busy and can help manage more serious ailments better. Do you think this is true?
Very correct. So in neighboring countries, I'll give a typical example of some of the neighboring countries that I have visited the healthcare system itself. There are services that should, like even using the NPHCDA itself, there's basic services that should be rendered at the PHC. So somebody having symptoms like fever, generalized body ache, has no business going to the general hospital or the teaching hospital. Those hospitals are supposed to provide specialized and tailored services, as opposed to you go into the general hospital, somebody comes in for And I'm not trying to underplay people's symptoms. Symptoms are just what the person is experiencing. They can mean something deeper, but symptoms or ailments, common ailments that should be handled at the primary healthcare should be handled at the primary healthcare, giving rooms for specialized care. So at the end of the day, the general and tertiary centers are not overburdened. Yeah. And that's what has been happening most times. A lot of people would prefer to go to those big centers. I actually agree with that if we get the primary healthcare working functionally and then they're optimal in terms of their service deliveries, the burden on the general and tertiary facilities will also decline.
Exactly. The World Health Organization Director General even says that investing in the primary healthcare could literally solve 85% of the primary health problems.
Yes.
And you could see that investing actually would go a long way, as well as awareness, just like you said. Mm-hmm. And I think it's something, of course, that is needed to be done. Because it's one thing to say you're just investing in just the development of the building and all of that, but the basic amenities, what needs to be developed, what needs to be invested in is not invested in, and of course we'll just keep going back in circles, right?
Which leads to the 4 A's again of primary healthcare, which is availability, accessibility, affordability, and the rest of it that comes with that. Which primary health, which is supposed to help give a universal health coverage to every single person who exists on earth. So just like you had mentioned, that 85% at least of that problem will be solved. So if I have a headache, I should not be finding my way all the way to the general hospital, when I can just stroll into a primary health care that
have yourself checked out. But can I also shock you and say that the primary health care itself is not only for curative itself. There's also the preventive aspect of it, the health awareness, the sensitization exercises. So it's basically a component that incorporates both the preventive, the curative, and then also like a comprehensive health system itself. Exactly. So it's actually a very beautiful system. If it works and if it functions optimally, we're going to see a beautiful improvement in terms of health outcomes generally.
Definitely. Thank you, Dr. Davidson. This has been such a knowledgeable and insightful conversation, I would say. We are hoping that more investment be put into the primary healthcare. Just like I said at the beginning, the primary healthcare is as important as the health of the individual receiving it. Thank you once again. Well, that's where we draw the line on timeline. I hope you've been inspired, and I hope you've had the awareness needed for, of course, this conversation. Well, I remain your host, Sharon Ajay. Until next time, see you again.
And I'm Hannah Omokafe Dennis, and if there is anything you should learn from today, is the fact that primary healthcare systems is for you, and you should be able to access it, afford it, accept it, of course, and just generally accept every single thing that comes with it.